Moving on. All right, what is a seizure? A seizure is a sudden, uncontrolled electrical disturbance in the brain. It can cause changes in your behavior, movements, or feelings, and is levels of consciousness. If you have two or more seizures or a tendency to have recent seizures, you have epilepsy. There are many types of seizures which range in severity. Okay, the
Mimi,
case
you have
study.
to move the picture, honey.
What picture?
Yeah, it's still on the first slide, baby.
I don't know what happened. I moved it. Oh man. Okay,
It's
hold on. Let me come back to you. Nope, it shows my screen is still going. Hold on. Can you, what is that? What do you see? That's me.
nothing.
Okay,
Yeah,
hold on.
I see all of us.
Okay. Back to this. You see it?
No, baby. Oh, okay, hold on, it's coming. All right, I see it.
Next page, you see
It's
it?
on the first, it's on the cover.
Oh, okay. I just want to point out Mimi. She put her new last name on this slide.
You're,
I underlined it.
oh, Jesus. Slide number two. Can you see slide number two?
Now we can, yes, if you
Okay.
push the button.
All right, so now I told you about the seizure. I already read that part. Okay, I can't do the slideshow apparently because that's what knocked you out last time. So I'll just go like this. The case study is Miss, I can't even say her name, so I'm gonna say Cinderella, is a 22-year-old female admitted admitted via EMS after a seizure witnessed by family members about 20 minutes ago. She has an IV in place. Y'all see that? All right, moving on. The resume slideshow. Let me try it. Can y'all see it?
Mm-hmm.
Y'all see it? Can you see it still, guys?
Yeah.
Yes, yes.
Yeah.
Okay,
Yes.
patient information, signs and symptoms found laying on the floor by family. Okay, so she is lethargic. She has diaphoretic. She's has localized pain. Her vital signs are within normal limits. She's not following commands, and she has cognitive and emotional symptoms. Okay. Moving on, my nursing diagnosis is ineffective health management related to deficient knowledge regarding seizure control, as evidenced by facial grimacing, staring off, muscle contractions, rhythmic jerking, noncompliance in commands, eye dilation, loss of consciousness and awareness, unawareness of seizure disorder. She's unaware she has seizures, guys. So my interventions for her is to create, and I spelled that wrong. No, I didn't. Nurse creates a safe environment in preparation for further seizure activity. Nurse will administer IV medication as ordered to decrease anxiety, because as you know, she had got administered that Ativan. Nurse will ensure EEG technician is on the way to
Change
place.
the screen.
It changed again?
No, you need to.
No, I did. I'm reading it.
I don't see nursing stuff. Number 5. We're still seeing signs and symptoms.
Okay, this getting on my nerves, y'all. This ain't my computer.
Sorry. I think if you just keep on clicking each slide that's on the
Yeah.
side.
Can you see it now? Yep.
Hold on.
You
It's
see it
coming.
now.
Not yet.
You should be able to see something.
Yeah, I see something. Now click on your next. Yeah, yeah,
There you
there you
go.
All
go.
right. So nursing interventions, like I said, I was going to create a safe environment for in preparation for further seizure activities. The nurse will administer IV medication as ordered. Like I said, she was on that Ativan to try to calm her down and get her mind right. The nurse will ensure the EEG technician is on the way to place the EEG electrodes. So I'm gonna tell y'all what an EEG is. That is when they come and they connect the things to your scalp, and then they're able to detect what type of activity you have going on in the brain. So that's why this technician is in need, because the doctor needs to see what type of seizures she has going on. Okay. The nurse will administer scheduled epilepsy medication, because she was also given Keppra and some other medications that will decrease the effects of the seizure and will get her not to have them in such frequency. All right. Nurse will teach coping and deep breathing techniques for non-pharmacological therapy. This can be a very exciting time. And when I say exciting, I'm not meaning in a good way. It can cause her to, overreact, hyperventilate, and whatnot. So we just want her to breathe. We need her to calm down. We need her to think about something else and meditate on something else. The nurse will schedule PTOT for strengthening and exercise. If you know anything about strokes, which can also occur after a seizure, you lose strength in your arms, in your hands, and your legs, and whatnot. So it's very important that you continue with some type of therapy that's going to increase your strengthening of your muscles and not let you get, stagnant in contractions and everything like that. Okay, so the nurse will encourage fluids and healthy nutritional lifestyle to reduce seizure triggers. At this point, she doesn't even know what's triggering her seizures. So by her being 22 years old, I can imagine that she's, a young adolescent, fresh out of the house, maybe be in college. She may be in her first job. She may be in her first serious relationship. They may have broke up. We don't know what's going on in her personal life. So we need her to maintain a healthy lifestyle. We need her to eat right, stay away from McDonald's, stay away from Hardee's, stay away from those fattening foods that's going to clog her, her arteries. I can't. Somebody's talking. What happened?
We're laughing.
Oh, okay, my bad. Let me keep going since y'all laughing. All right. So the expected outcomes, right? The expected outcomes, you need to keep some symptoms. You will keep some symptoms even after the seizure activity in your brain has stopped. This is because some symptoms are after effects of the seizure, like sleepiness, confusion, certain movements, or being unable to move, and difficulty talking or thinking normally. Okay, so the patient will be able to identify triggers of seizures by discharge. Patient will regain functionable level of consciousness by the end of the shift. The patient will be able to understand medication administration of seizure prevention drugs. Patient will have decreased muscle tightness within 2 hours of medication administration. And because Evelyn is in my way, I can't see that last one that's on the right-hand side right here. What's the last one I didn't read, guys? That one right here.
All right,
Okay, moving on. So I put in here the medications real quick, right? I said, Evelyn, that don't mean get out of the screen. Thank you. Okay. I put right here the medications. They put her on some benzodiazepines, which is Ativan IV or Valium or whatever. Again, we need to calm this lady down. She's thinking a lot. She got a lot going on. She's having an anxiety attack along with these seizures. We put her on barbiturates like phenobarbital. Boy, I can't talk. We put her on an anti-epileptic drug. Then she's on that the levotriacetate. Yeah, I know it is Keppra.
Keppra.
Right. Yep,
Keppra.
I know it is Keppra. All right, and again, I just showed you a picture over here with abnormal electric impulses during seizures in the brain. So that's what's going on with her right now. Moving on. I don't know this computer, y'all. Sorry. So we have stages of seizures. They're different stages. There's a ERNA, there's a tonic, there's a clonic. I can't pronounce none of this. There's a post-ictal stage. Professor, I know you know how to say all of this. Anyway, seizures can happen after a stroke.
Post-ictal.
Yeah, that right there. Yes, ma'am. Thank you. Seizures can happen after a stroke, a closed head injury, or an infection such as meningitis or other illnesses. Many times, though the cause of seizures are unknown, most seizure disorders can be controlled with medication, but management of seizures can still have significant impacts on your daily life. All right, so I'm gonna give you a little bit of education, and that is saying that we're talking about grand mal seizures. We talked about the tonic seizures or whatever. Witnessing a person having a tonic seizure can be upsetting, but it's important to remember that most seizures resolve on their own after 1 to 3 minutes. So what do you want to do? You want to ensure that the environment is safe for the person and the person that is standing by. You want to turn the person on their side, get help, and do not restrain the person. I repeat, do not restrain the person. Don't hold them. Don't put nothing in their mouth. Back in the day, they used to tell you to put a popsicle stick or something in their mouth to hold down their tongue. Don't do that. Just let them wild out. If they bite their tongue, it's okay. We might can sew it back on. But don't put nothing in their mouth trying to, get them not to bite their tongue or whatever. Just make sure that they're safe as possible from anything that's around them or surrounding them. Time the activity from start to finish. And that way, if it lasts longer than a couple of minutes, you need to go ahead and call the paramedics because they're going into having a stroke or they could be going into having a mitochondrial infection. What I did with this slide was I went ahead and included the nursing care plan, which was going to be the next topic of interest as Professor So wanted it. And again, I had already put on there about, her poor health, her ineffective health management related to deficient knowledge regarding seizure control as evidenced by recent loss of consciousness and acknowledgement of failed medication regimen precautions. Okay, she came in. She said she had localized pain on of 9 to 10. She said she had tingling in her arms. She reports feeling fuzzy and loss of awareness. What I saw when I observed her was rhythmic jerking. I saw unresponsive to commands, and I seen her eyes were dilated, and she has stiff body ligaments. Now, just because she has stiff body ligaments doesn't mean she wasn't jerking. That just means it was more of it was really tight or whatever, and then she continued to jerk. I wish I had a picture to show you, but I don't. All right. So the goals and the outcome. Statement number 1, the patient and the family will be aware of dangers associated with seizures, how to stage a safe environment as much as possible, what to do in the event of its rapid onset, how to calculate the length of time it occurs, and when to call for assistance by patient's discharge. Anticonvulsants and anhydrous inhibitors should be taken as prescribed as a precaution, and patients will understand the risks of not following this regimen by the end of the shift. Routine testing by the neurologist and the healthcare provider should be monitored to check her brain activity and status routinely. Therefore, patient understands to make follow-up appointments within 24 hours. My next statement of goal or outcome is going to be education of lifestyle changes, decreasing stressors and strenuous activities that may cause high frequencies to the brain circuits is necessary to reduce high frequencies that cause seizures activities. Patient will be able to create a plan of action to incorporate such changes prior to discharge. Okay, my nursing interventions, if I'm going too fast, let me know. My nursing interventions is that the nurse creates a safe environment in preparation of further seizure activities. Like we said, we don't know when it's going to happen. It just happens. So we're going to make sure that she's in a safe environment. What that means is you lower the bed to the lowest positions to prevent injuries. You make sure that she doesn't have anything electrical next to her that has her like water pitcher or whatnot next to it either. Okay. Then we're going to I'm going to go ahead and administer that IV medication, which is a push, and schedule epilepsy medication, as we already talked about the benzos and the Keppras and all of that. Medication administration is to reduce the severity and the frequency of the seizure activity, and to reduce her anxiety while she's going through this time. We know that she has stressors and fears that could be the cause of some of the brain activity stimulation. We're also going to do nursing will ensure that the EEG technician is on the way to place the electrodes. The sooner the technician gets there, the sooner the doctor will be able to see what type of seizure she's having and what's going on with the brain waves in her head, which will give him a better way to diagnose the situation. Okay, the next one is provide one-on-one teaching on seizure management. The reason for that education is that the disorder can cause awareness and cause caution on potential triggers that can assist in reduction of occurrences. Nurse will encourage a healthy and balanced nutritional lifestyle to reduce seizure triggers. Again, because she doesn't know what's necessarily going on, we need to sit down with the patient. We need to talk to them, see what's going on in their life, and see how we can help them reduce their stressors, how we can get them to do a nutritional thing. No, it's not like hypertension where you got to have a different diet. No, it's not like cardiac where you got to have a cardiac diet. But at the same time, because we don't know what's going on, maybe that fast food is causing her to have some type of reaction that goes on and stimulates her brain activity, or her alcoholism. She's 22, so how far we know she's the beginning stage of an alcoholic. So we want to make sure that she knows that she don't need to be drinking all of that, and that she needs to have a balance and a healthy lifestyle. Okay, having a balanced and healthy lifestyle and ability to reduce triggers can create a more stable mindset that can assist in controlling epileptic outbreaks. Nurses will schedule PTOT for strengthening exercises. So what that means is muscle weakness and tightness can be caused by seizures. Being able to maintain strength and balance after activities will create a healthier internal body system in the event for further seizures or paralyzing activities. So when you have seizures, sometimes you go into that paralyzed state temporarily or whatever. When you come out of it, you like I said before, you don't feel as strong as you used to, and you might have lost some type of gripping or whatnot, or range of motion. So you're going to make sure that you know what to do in order to get your strength back, or to regain your strength, so that in the event that it happens again, you can have some type of stability going on within your body. So for my outcomes, upon active seizure activity, there was no There was no injuries. Her anxiety medication was ineffective, and it took too much of an additional time for the other medications to kick in. Hence why the EEG testing was achieved and it was successful because the doctor was able to continue on with his diagnosis. For the outcomes number 2, the patient was receptive of the teaching and provided teach back information and precautions of management. The patient agreed to mediation, not meditation, I'm sorry, and counseling to reduce her stress and anxiety. And I'm not sure what I got the last one up because I see a beautiful picture of Professor Fletcher in a circle and it's covering my last little dot. I don't know if I can move it because if I do, I might get out of it. So that's what I have for that, ladies. I would ask y'all if there's any questions, but here goes the questions. If Professor wants to go over them right now.
Wait till the end, Mimi. Let me go over the questions afterwards when all of us have done it. That
Yes,
was
ma'am.
incredible. In fact, I'm probably going to get you to do the lecture tomorrow.
Oh, Jesus.
But yeah, I would rather do the questions all together.
Yes,
So
ma'am.
let's do that.
Okay.
And let me see who wants to go next.
Follow that.
I can go next. Let me try to share
Okay.
my screen.
All right. Fantastic.
Let's see. Where did I put? I'm sorry, y'all. Hold on just a second. My computer is so slow.
I live right here at Marshall.
All right. Now I can actually talk a little bit more. Well, first of all, Mimi, while Rhonda's getting that together, that was incredible. You did such an awesome job. Do you have someone in the family with epilepsy or has had
No, ma'am.
seizures?
No, ma'am, I don't. It's just my experience being a nurse.
Yeah. Do you find that subject interesting?
I do because, like you said, there's no known reasons really. One of my clients currently, she has all the time. She has grand mal like every day. That's just a part of her activity. She was diagnosed with cancer at birth, and as a result of that, amongst other things that's going on with her, she has these seizure activities constantly, and they just happen at the drop of a dime. So it just amazes me how the brain circuits work and the neurons and the neurometers and everything else and the axons and everything else connect and just because even people with migraines, people don't think about this, but people with migraines can also have seizure activity and don't even know it. You can have seizure activity in your sleep and don't even know it. So you know how many people there that are out there that can actually be suffering from seizures and don't even know it. So yeah, it amazes me. It's something that I actually wanted to get into further, but I won't while I'm in nursing school because it can drive me crazy.
Yeah. Yeah, I think it's absolutely incredible. And it's interesting. I saw a patient on Friday who was on Keppra. I asked him why he was on Keppra, and he actually has a brain tumor. And that's why he's on Keppra. And he's noticing some left-sided tingling type of sensations, not having seizures. But guess what? This guy smokes and drinks.
Right. Yep. Underlying cause. Risk factor.
I'm like, okay, we have to deal with that. We have to deal with that. All right. Okay, Rhonda, you're up.
Okay, are we doing a concept map or just a character plan? Professor? Hello?
She muted herself, but I think we're supposed to do both.
You were to do both.
Oh, okay. All right. Okay, I did for the concept map for seizures and epilepsy. And it's a seizure is an abnormal, sudden, uncontrolled electrical discharge of neurons within the brain that may result in a change in level of consciousness, motor and sensory ability or behavior. It's a single seizure may occur for no known reason, or some seizures are caused by pathologic conditions of the brain, such as tumors. The risk factors for seizures is metabolic disorders, acute alcohol withdrawal, electrolyte disturbances, high potassium, water intoxication, and low insulin. Fever, head injury, and 6 and 7, substance abuse and heart disease. The assessment findings you need to do is ask the patient / ask the family or the patient how many seizures the patient have had, how long haven't had any long patterns, signs and symptoms of the seizures, and ask about particular phase presence of a neural, ask about medication or herbs, head trauma or fever, stroke or hypertension, and if any new seizures, ask about level of consciousness in past or in childhood. Now the drug therapy is the AEDs for the intervention. The CBCs, the liver enzymes, and assess for therapeutic drug levels, and observe for gingival hyperplasia. The second one is surgical management, which is the VNS, the vagal nerve stimulation. And the third one is partial corpus callosum, tonic-clonic or atomic seizures. And laboratory findings is a variety of diagnostics are performed to rule out other causes of seizures, activities, and to confirm the diagnosis of epilepsy, which is the EEG, the CT scan, the MRI, the SPECT, and the PET. For my head to toe objective and subjective data, I put for objective, her muscles are cycling back and forth between tight contractions and rhythmatic jerking. And for subjective, I put she is lethargic, localized to pain, but does not follow commands, and she is diaphoretic. For my nursing diagnosis, I put ineffective airway clearance related to perceptual or cognitive impairment, decreased energy and fatigue. The patient outcome was patient will always maintain a patient airway. The nurse outcome was turn patient head to stop to prevent aspiration, and the rationale for that is to prevent patient choking. The second nursing diagnosis is interrupted family process related to situational crisis. The patient and family will demonstrate knowledge of illness or injury, treatment, modalities, and prognosis. The nurse outcome for that one was nurse will collaborate with family and problem solving and decision making on additional effective coping skills for their own use. And the rationale of that was it creates a systematic approach to disease management and it incorporates the family as part of the care team and improve patient outcome. The third one was risk for injury related to altered mobility, sensory dysfunction, cognitive impairment, which means the patient will explain methods to prevent injury. And a nurse will identify clients who are susceptible to changes in health status. And the rationale was that will report decline in mental and physical status. The fourth nursing diagnosis is impaired memory related to neurological disturbances. The patient will state he or she has improved for everyday concerns. Improve memory for everyday concerns. The nurse will assess overall memory and function, and that can be to determine if patient has cognitive impairment.
All right.
And that's it.
Thank you very much. You like doing it just on the paper. You did a good job.
Yes, ma'am. Thank you.
Yeah, welcome. You're welcome. All right, who's up next? Elisa, Evelyn, Kaylin.
Elisa, do you want to pull up my stuff? Or do you want to go first?
Has anybody had to deal with somebody having a seizure, by the way?
Not me.
Anybody
Yes,
had?
I did. In clinicals one time.
Yeah. On a neuro floor or out of work? Anybody?
No.
Like I
Not
said,
on
not
the
out of work. That's my little kid,
yeah,
and she's
not on the
15.
word.
Yeah. 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 It's a lot of these things that we're talking about.
Professor, you know
Especially-
we're not recording, right?
No, we are recording.
Oh, okay.
Yeah. Yeah. A lot of the things that I'm discussing that you're pointing out, and one of them especially regarding the fact that you don't put anything in the mouth and basically put them in the recovery position and make sure they're safe. And that's really what you're going to be doing with them. I've had to manage patients. I'm on the streets, actually. I've had situations on the streets with patients that has occurred with. And quite frankly, you know, you've got to be prepared to just be there for that patient until they come out of that seizure. Of course, you're going to dial 911 and all the rest of it as well, but you're just making sure that they stay safe and that their airway is patent in that time frame as well. So just in case you ever come across it in the outside of the hospital environment. All right. Evelyn, are you ready?
If Alyssa can pull it up for me, I can. I sent her my stuff. Okay. All right, ladies. I did a separate concept map. That's not part of this. And I can't do any pictures. That's the best I could do.
Yeah, you stole our thing from the other week too, but I ain't gonna say nothing. Keep going.
What did I steal?
Mhm.
That's the only thing I know how to do, man. Okay.
Come on, babes, you got it.
So it's seizure disorder. It's also known as epilepsy. It's a brain condition characterized by recurrent events associated with abnormal electrical discharges of neurons in the brain. The discharge may trigger a convulsive movement and an interruption of sensation and alteration in the patient's level of consciousness, or in a combination of these symptoms. In most cases, epilepsy doesn't affect intelligence. It affects people of all ages, races, ethnic backgrounds. About 2.5 to 3 million people have been diagnosed with epilepsy. And my little note on the bottom is the incidence of seizure disorder is highest in childhood and old age. The prognosis is good if the patient adheres strictly to the prescribed treatment. How it happens, this is a little bit of the technical side. The electrical balance of the neuronal level is altered, causing the membrane of the neuron to become easily activated. Its increased permeability of the membrane helps hypersensitive neurons fire abnormally. Abnormal firing may be activated by hypothermia, hypoglycemia, hyponatremia, hypoxia, or repeated sensory stimulation. When the intensity of the seizure discharge has progressed sufficiently, it spreads to adjacent brain areas. The midbrain, the thalamus, and the cerebral cortex are most likely to become epileptic. That means producing epileptic attacks. Excitement feeds back from the primary focus into other parts of the brain, and the discharges become less frequent until they stop. Next. All right, and then I went into generalized, partial, and unclassified seizures. Generalized seizures occur as the misfiring signals across both hemispheres. The patient loses consciousness and has body-wide uncontrolled muscle spasms. For partial seizures and complex partial, I don't know, I think I went crazy on that. Complex partial seizures may begin in one hemisphere, but it quickly moves into both hemispheres. The patient commonly stares into space, unaware of the environment. The patient may make purposeless movements. Simple partial seizures begin in one hemisphere of the brain. One part of the body is usually involved in involuntary movements. The patient doesn't usually lose consciousness. Unclassified seizures, which that's a lot of times. These seizures account for about half of all the seizure activities. They occur for no known reason and do not fit into the generalized or partial classification. What to look for? Could start with auras, pungent smell, nausea or indigestion, rising or sinking feeling in the stomach, a dreamy feeling, and an unusual taste, visual disturbances such as a flashing light. And then when the seizure starts happening, it's stiffening followed by muscle contractions, tongue biting, incontinence, blank stare, purposeless motor activities, change in level of awareness, loss of posture tone, and jerking and twitching. Next. Diagnostic evaluations are EEGs with or without video monitoring, locates epileptic focus, spread, intensity, and duration, helps to classify the seizure type. CT scan or MRI identifies lesions that may be causing seizures. Single proton EMS emission CT or position emission tomography, which is a PET scan. These identify the seizure's center of interest or activity. Neurophysiological studies evaluate for behavioral disturbances, which is like the assessment of the cognitive function. Laboratory and blood tests, electrolytes, glucose, and toxicity screen help determine the cause of the first seizure. Lumbar puncture and blood cultures may be needed if the patient presents with a fever. I assume that's because they could have meningitis or something like that, why they would do that they're not sure what they have. Pharmacological and surgical interventions. I listed epilepsy medicines. I just listed a couple of them. Surgical interventions would only be needed if they have a brain tumor or hematoma. Also, there's other surgeries, temporal lobectomy. Can you just pull that up? Yeah. Temporal lobectomy, extratemporal resection, corpus callosotomy, hemispherectomy may be necessary in medically to do intractable seizure disorders. The epilepsy medication is, I just listed the basic stuff. This is my nursing care plan is next on seizures. And I kind of used some of what went on with the patient that we were looking at, and then I just added some stuff. These are some possible things that we might come up with, present with. Subjective data, loss of awareness, confusion. Patient may report an aura before the seizure, drowsiness, nausea, vomiting, and headache. Objective data, you can usually see twitching, stiffening, stiff contractions, loss of consciousness, and they stare off blankly. The nursing diagnosis that I used would be for risk for injury, because they're susceptible to physical damage due to environmental conditions, interacting with the individual's adaptive and defensive resources, which may compromise health. And then the risk for suffocation, vulnerable to inadequate air availability for inhalation, which may compromise health. My nursing interventions were monitor the entire seizure event, include early signs and symptoms, seizure behavior, and state of consciousness, Monitor all vitals, complete blood count, urinalysis, liver function studies for toxicity caused by medication. Maintain the patient airway until the patient is fully awake from seizure. Provide oxygen during the seizure if the patient becomes synototic. Place the patient on side during a seizure to prevent aspiration. Provide safe environment by padding side rails and removing clutter. Protect the patient's head during a seizure. Do not put anything in the patient's mouth during a seizure. Do not restrain the patient during a seizure, and place the bed in the lowest position. Next. And then for my patient teaching, we would do care during a seizure, safe environment, nothing in the mouth, no side, on side to prevent aspirations, continue prescribed drug therapy, teach the patient stress reduction techniques that fit into the patient's lifestyle, such as meditation and music therapy. Encourage the patient to determine existence of triggering factors to procedures, such as skip meals, lack of sleep, emotional stress. Encourage patient to follow moderate lifestyle routine, include exercise, mental activity, and nutritious diet. Tell patient to avoid alcohol because it interferes with their metabolism and also adds to their sedation. Safety precautions and activity limitations, no driving. Need to wear a mental alert identification card or bracelet. Look for potential behavior changes, and look for availability of support groups for them. Also maintain regularly scheduled laboratory testing and medical checkups with your physician. The desired outcomes, that they verbalize outstanding factors that contribute to the possibility of the injury or suffocation, and take steps to correct the situation if that would happen. That they know what to do. We know what to do. Identify actions or measures to take when seizure activity occurs. Identifying correct potential risk factors in the environment. Demonstrate behaviors, lifestyle changes to reduce risk factors and protect self from injury. Modify our environment as indicated to enhance safety. Maintain treatment regime to control or eliminate seizure activity, and to recognize need for assistance to prevent accidents or injuries. And if you have any questions.
Beautiful, my darling, beautiful.
Thank you. There's no pictures though. And then I did a separate.
I'm trying to unmute. That was incredible, Evelyn.
Thank you.
Absolutely incredible. A couple of things I just want to bear in mind as well. You did mention some of the medications. One of the things I want to just talk about when we talk about the blood draws and basically maintaining blood levels is, what are we going to maintain? What's one of the big meds that we have to look at? Pardon?
Don't we have to keep looking at the Keppra levels?
Dilantin.
Oh, Dilantin.
Yes. Yeah. Phenytoin, Dilantin has a very narrow index. That's one of the ones we have to be really careful with. You can get Dilantin toxicity very easily.
I knew it was one.
Phenytoin toxicity very easily.
You're right.
Excellent job. Thank you. Did you enjoy doing it?
Well, it stressed me out. I can't get pictures in. I don't know how to do that. That's the best I could do.
To get pictures on the PowerPoint?
Yeah, I don't know how.
I'll have to show you. I'll show you on our one-on-ones.
And I did just a separate concept map that you'll see that I turned into my stuff.
I'll show you on the one-on-ones how to put pictures in a PowerPoint.
Okay.
When you see it, you'll go, oh my gosh, not that bad.
Well, that was pretty good for me.
You did a great job. It was awesome. All right. Who's next? Kaylin.
Yeah.
Elisa.
It doesn't matter.
I can barely talk still.
Oh, you.
Oh,
Yeah, I don't think you guys want me to. 'Cause
you
it's
sound like
more.
you got the cooties,
Okay.
girl.
No, it's
Can
not.
you? Well, you can go. You go last, and that way you can just show us what you did. Okay. You don't have to talk it. You can just show us your slides afterwards. All
Good.
right. Let's see yours, Kate.
Okay, so hold on. Let me pull it out. I'm gonna just say that I ain't as fancy as everybody, but you get the point. Okay. How do you share the screen? How do I share the screen, guys?
Down the bottom, you should see a thing. When you click on the bar, it should say share screen, and then it should show all of the sections that you have up, and you just click on the one you want to share.
Oh, okay, hold on. Can you see that?
Yes, we can see it.
Okay, this is my care plan. For my nursing diagnosis, I chose risk for trauma. For my objective, I got the localizing pain, diaphoretic sweating, whatever. The patient is jerking, and then for the subjective, the facial expressions. And for the goals, the first one was the patient will identify actions or measures to take when seizure activity occurs. And the first one was support head placed on soft area or assist to the floor if out of bed. Do not attempt to restrain. Um, the rationale behind that is supporting the extremities lessens the risk of physical injury when the patient lacks voluntary muscle control. Two, reorient the patient. Patient may be confused, disoriented, and possibly amnestic after the seizure and need help to regain control and elevate anxiety. Uh, Three, explain seizure warning signs and usual seizure patterns. Knowing what to do when a seizure occurs can prevent injury or complications. And I said this is an ongoing goal because it's not just going to stop overnight. So it's something that the patient should know um, from here on out if it occurs again. For the second statement, patient will maintain treatment regimen to control or eliminate seizure activity. And for the nursing interventions, I just put the different meds that were in the case studies, like the Ativan, the AEDs, and I don't know how to pronounce that word, the something, um, whatever. And for each of those,
You mean Keppra? Are you talking about Keppra?
yes,
Levitrititam or something? Yeah. Okay.
yeah, that. And for each of those meds, the Keppra, the Ativan, and the AD drugs, I just put in my rationales what exactly uh each med does. As you can see, like 1, 2, 3. Um, for the goal for that, I just put ongoing because the meds would be something that the patient would have to maintain over time with the seizures happening. As far as my okay, hold on. And as far as my concept mount, I just put here, where is it? I just put the different. I just put different slideshow. Hold on. Hmm. Okay, my computer. Oh, sorry. I put what is epilepsy? A disorder in which nerve cell activity in the brain is disturbed, causing seizures. Epilepsy may occur as a result of genetic disorder, or and excuse me, or in how we pronounce it, brain injuries such as trauma or stroke. And then I just put like I put the patient's name, Miss, like Mimi said, Miss Cinderella, because I can't pronounce that. Um, I put the different data that from the care plan, like the muscle contractions, the sweating. She was lethargic. Her stable vital signs and her muscle tightness. For the and then for safety, I put that you should monitor the O2 stats, turn the patient on the side. Um, she should have padded side rails, and suction always available at all times. And I think I spelled available wrong. I did. Risk for trauma, weakness, muscle coordination, reduced sensation, and altered consciousness. And that was it for me. Mine didn't look like everybody else, but yeah. And that was all that I had.
Are you talking, Kaylin? Because I can't hear you.
Not anymore. I'm done now.
You finished? Okay. All right. Okay. Elisa, can we somehow see your slides? At least see what you worked on? I know it's. Do you have laryngitis? What's going on there?
I was at work, and the floor they had me on is old, and you can smell the mold and mildew. I'm allergic to those, so for 2 days straight of that floor, it finally got the better of me.
That's. Oh my gosh. What are you doing for it? Are you doing? I mean, other than resting your voice.
I'm gonna let it pass because in a couple days it'll go away.
Okay. Okay.
All right.
All right. Well, let's at least see what you did, if you're able to just sort of show some of your work.
That's pretty, Elisa. If you want to go over the beginning, if you want me to read it for you, I can. Uh-oh. It's stuck.
Has it got stuck?
I think so.
My old computer froze. It just froze.
Yay, Lisa, you tried.
Yeah. And back, guys. Thank you for your patience with that. Let me turn this thing on.
Sorry.
Okay. All right, so you had a hard time pulling yours up. Some of you did some amazing work. Elisa, have you had the opportunity to work with seizure patients?
I've worked on that floor, but I personally don't because their team is trained what to do when something happens.
Mm-hmm. Makes sense. That makes sense. So let me just pull up Canvas a second. Actually, let me pull up a couple of things. Bear with me. I mean, most of the time, unfortunately, it's a case with those types of patients. I mean, you don't know when it's going to happen. And I mean, to an extent, you don't know when it's going to happen, but you can do the best you can to take care of them, of course. Here we go. Okay. Give me a second, I'm just pulling something up. On my various, thank you for your patience with that right now, unfortunately. Are you taking saltwater gargles at all? Okay, good. Yeah, probably some, maybe spray or something, some lidocaine spray or something like that. No?
So, Professor, where you work at so you can be my primary care doc? You know what I'm saying?
Seriously? Yeah. So I work at Jack's Beach. I see all insurance. I take all insurance.
Hi, Karen.
I work with a physician. Let me put her info in here for you. It's L.A. Quinn MD.
I'm serious. Okay.
Yeah, L.A. Quinn MD. And as I say, my passion, and actually this Friday lunchtime, we're doing a Facebook Live talking about hormones. Because as I say, that is my thing. That's what I like to do. So I'm actually going to be doing that this Friday. I should try and send you guys the link to it. But yeah, I think it's very underrated. Funny enough, talking about seizures, one of the things that unfortunately can be an effect of seizures is the fact that the hormones are not dealt with or not taken care of. So I think there's a lot of issues that we don't take into consideration with hormones. But anyway, so this patient, so you all did the questions, didn't you, on this particular patient, right?
Yes, ma'am.
And so let's see, what initial nursing assessment needs to be performed for Mr. or Mrs. Cerulean? Cerulean. That's how I'm going to say the name anyway.
What do we think? You
Uh,
can type it in the chat box if you can't talk.
I think she was just young and had some issues going on, didn't know she had them, or maybe did know she had them and just didn't know how to manage them. If that's what you mean, what we think about it.
Well, what initial nursing assessment? So you're going to do a full set of vitals, right?
Do the neuro checks first.
Thank you. Neuro checks, level of consciousness. You're going to check her pupils. You're going to see if anything, you make sure she doesn't have a blown pupil, nothing like that, okay? She's lethargic. She localized pain, so you can pinch her and she's going to be able to react to that, right? She doesn't follow commands though. She's diaphoretic, vitals are stable. Let's see, she's in a post-ictal state, meaning she's just had the seizure, and low level of consciousness. So let's see. It says here that suddenly the patient begins jerking. Her muscles are cycling back and forth between tight contractions and rhythmic jerking. What is this called? So what did you guys put for that?
I gotta pull it up.
Yes, correct. Well
Tonic
done.
phase.
Yep, that's exactly what it is. Tonic-clonic. Yep. Tonic-clonic generalized seizure. Well done. And of course, we're going to do the things that you talked about. You're going to keep her safe, pop her on her side, make sure nothing's in her mouth, of course, but you know, you're going to make sure, of course, as much as you can. You're going to make sure that airway is patent, keep it open, monitor her SATs, apply oxygen. You're going to not restrain her. It does say about padding the side rails, but in the book, it sort of says there's some talk about not doing that so much because there's really the stats are not really showing that there's a lot of injuries secondary to side rail injuries, but it can be embarrassing for the patient. So I don't know, they're tending to say that a lot of places aren't doing that. I don't know if that's true or not. Those of you that are working actually in the hospital might know if that's the case. So Lisa is saying they do pad the side rails. Yeah.
They took the side rails out of our facility completely. So I'm sorry, when I was working at the nursing home, I worked at Lanier Terrace Nursing Home or Lanier Rehab off of Lanier Road. And they took the side rails off of our beds completely. And that had nothing to do with people having seizures. They just took them away. So now the precaution is they have mats that go on the side of the bed that if they fall, then there's like this thick mat. And then we also have this it's called a weighted blanket that we place on them as well.
Okay. Well, that might work better. I know they have concerns about people going over the side rails and things like that. So, all right, what meds would you expect to give to Miss? It keeps saying between Mrs. and Mr. I'm going to say it's a Mrs. Cerulin. So we've got your benzodiazepines, right? Ativan or Valium, and you don't have to just give that. You can give it rectally. Remember, if for whatever reason, obviously you can't get it in orally, and you may have blown a line or something like that, you can give it rectally. Barbiturates as well, and your phenobarbital are the other things, and your anti-epileptic drugs. I can't pronounce it either. I always have to say Keppra, I'm sorry. Phosphotoin. And when we go over it on Thursday, I'm going to go into more detail about phosphotoin and also phenytoin. Remember, as I say, that concern about the fact that you've got to really manage that medication carefully and keep their levels, I want to say below 20 is what I recall off the top of my head. So this particular patient gets Ativan push. She continues to seize, which is really concerning. And they're going to intubate this patient, right? So it looks like they give her some Keppra, they give him phosphotoin, and they do an EEG, which is pretty standard procedure for your epilepsy patient, an EEG. So what is the name of the condition that this patient is now in? Because this seizure has gone on for more than 10 minutes, right? Anything that's more than 10 minutes, what is it called?
Where is it? It is called
Yeah, I think you said it.
Status epilepticus.
Yeah, good job. You got it. Exactly. All right. So the purpose of the EEG, what are we doing here? We're measuring brain activity. That's what we're doing. It can also determine how severe the seizures are. It can also pinpoint where the seizure is originating. So there's a few different signals with the EEG. Let's see, it's obviously can indicate whether they're still seizing or whether the seizures have stopped, even if they're not actually got any physical manifestations of that. And even after the phenobarbital or a paralytic med is administered, they still can tell whether they're having seizures or not, especially if they've got a paralytic on board. You may not be able to obviously physically see what's going on with that patient. Seizure plans, how to keep the patient safe in the event of a seizure, right? This includes knowing how to administer their meds, but also the understanding that they need to stay on those meds. They can't come off those medications, right? That's really a non-option. People
Professor,
think, yes.
let me tell you. So my 15-year-old client, right? She's on Keppra and she's on varapic acid and she's on Keppra varapic acid and then clozapine
Okay.
or something like that. And her mother, I mean, when I tell you it pisses me off to high heavens, her mother, whenever they have any type of gathering, like they got family or somebody coming over or whatever, she likes to tell me, oh, well, hold this medicine because I want her to be, I want her to be interactive with everyone else. I said, I'm not holding the medicine. I said, because I'm holding the medicine because I know that something's wrong. There's nothing wrong. You just want her alert. And that seizure medicine has a tendency to put you to sleep. It makes you very drowsy and very, lethargic or whatever. So it puts you to sleep or whatever. And she doesn't want her to be asleep. She wants her to be interactive. And that's not a reason. So long story short, other little nurses who haven't been nursing, I'm not coming for anybody that's not a LPN or hasn't been an LPN for a long period of time, but anybody knows that you don't just stop giving a medicine for a specific reason. So the other nurses do it. I see the circles around it. I call back to the agency office and I'm saying, is there a reason? Was there a doctor order that I didn't see? The reason why we're holding this medication? So needless to say, not on purpose, I got like 4 people in trouble because they're holding this medicine because the mother said so. And what makes it so bad is she's a Concord student. I'm done.
Yeah. Wow. Well, yeah, no, you cannot hold this medication. Some of them have a pretty short half-life as well. So you have to be
They're
careful.
probably holding the clonazepam, right?
What'd you say?
They're probably holding the clonazepam.
The clozapine is PRN, but they're holding what they're holding is the Keppra and they're holding her varapic acid.
They can't hold the Keppra. I can see them holding the clonazepam, but not the Keppra.
But the clozapine is PRN. But here's the thing: she needs a clozapine like at least once a shift because how much she has them grand mal seizures, and it's a lot. And like I said, she's 15, so.
Well, and again, we just talked about hormones, right? So she's 15.
And then she's on Depo-Provera, and because she's on the medication. She's on, I seen Elisa's face. She's on Depo because she still has periods, and her mom's trying to prevent her from being any pain or bleeding. What'd you say? I think you said it's bullshit. I think that's what you said. Okay.
Me? No.
Elisa.
Yeah. I don't know, but it sounds like quite a disaster going on there, unfortunately. Yeah. Mom is not smart. No, she is not.
Oh, yes.
Yeah. Wow. All right. Well, let's finish up this. So she's on a phenobarbital drip. As I say, we've also got the Keppra and the phosphophenatoin going. The EEG slowly shows decreasing seizure activity. What's the risk of prolonged seizures? What do you think? We talked about neurons this morning. So, obviously you can have long-term neurological damage, right, to these neurons that are being fired up all of the time. Airway compromise, of course, that can also lead to brain damage, hypoxia. Yeah, so you've got a couple of issues going on there that are not really helping this patient in the long haul. Patient is awake, thankfully doesn't have any neurodeficits. She can ambulate. They're going to discharge her. So now we're talking about some education topics. So some of the topics, one of the biggie we just talked about is compliance. And I know that you guys have talked about some of the other pieces as well. Looking at different factors that can trigger. There are many factors that can trigger an epilepsy situation. Are they going to be able to drive? Some of them think they can, right? Probably not a good option with somebody with epilepsy. Making sure that they have a safety plan in place, like some of the things that you talked about. So I just wanted to go over those questions a little bit. And I think a lot of the information was in chapter, I want to say, was it 42, 41, 42, 42, a lot of the information that we talked about. And then on Thursday, I do want to delve into it a little bit deeper and talk about it. But you guys did a great job. I really like the concept maps. And as I say, I think the concept maps help you to then develop the other pieces as well, the care plans. So what I want to do is, I think, seeing as though you all were able to give me feedback, what I want to do is for Thursday, just let me know in the chat box. I want to do one-on-ones with all of you, please, on Thursday, half-hour one-on-ones, starting at, say, let's see, we finish at 12. So let's say from 2 till 5.
Can I have the 2 because I have to go to a funeral. I have to take my mother to Alabama for a funeral.
Absolutely, absolutely. Anyone else want to let me know now? Well, I might as well just do it now as soon as I got you.
I'll take any time.
Right, so let's see. Mimi's 2 till 2:30.
What day is this? Yeah, Thursday.
Thursday, is that okay? If that doesn't work, I can do another day.
Thursday's good for me.
Okay. Evelyn, you 3. Okay. Elisa put 3 to 3:30. Rhonda, what time am I meeting with you, please?
I'm at 3, you said, right?
Mm-hmm.
I'll take 3:30.
Is that Caitlin?
Mm-hmm.
Okay, 3:30 to 4. Okay. And Evelyn?
Oh, yeah, what time?
Let's see. Do you want to do 1:30 till 2?
Sure.
Okay, Rhonda, I need you to answer me, please.
Did you call me?
No.
Yeah.
Rhonda.
Turn this on.
Okay. Hopefully she'll call me. All right, so Evelyn, you're from 1:30 till 2.
Okay.
Mimi, you're from 2 till 2:30. Kaylin, or rather Elisa, you're from 3 to 3:30. Kaylin, 3:30 to 4. And fantastic. And I'm just going to have to wait for Rhonda as well. All right.
I have stepped away.
I'm sorry? Hello?
She said she stepped away.
Mm-mm. No answer. Okay. All right. I'll take care of that. Probably do. Okay. All right, guys. Oh, let's see. I didn't hear what she said. 3. That's already been taken, Rhonda. Can you do 3:30 to 4? Let's do 3:30 till 4 p.m. Okay. 3:30 till 4. Someone just beat you to the 3 o'clock slot, unless she's willing to switch.
I thought I was 3:30 to 4. What?
Miss Fletcher, what time do you
Oh,
have
sorry.
down for?
Okay, yeah, Kaylin got in at 3:30 to 4. Can you do 4 to 4:30, Rhonda?
On what day it was?
It'll be on Thursday.
Yes.
4. All right, great. So it'll be, all right, so 4 to 4:30. All right, perfect. All right. I tell you what I'll do, I'll send an email when we finish class of all of this. So Evelyn is 1:30 till 2. Mimi is 2 till 2:30. Elisa is, Kaylin is 3:30, and I have Rhonda 4 to 4:30. Is that right? Does that sound right? I think so. Do I have a bad network? Okay. All right. Okay. Well, I've enjoyed seeing your PowerPoints. I enjoyed seeing your care plans. We will meet Thursday at 8 a.m. and go over 4 chapters. This week, thankfully, you don't have a quiz or an exam. So, just take this extra time, really start delving in to your dosage calc and sort of just going through the areas that you don't feel a level of comfort with. And I think what I'll do next week is try and organize, maybe on Wednesday, if I can, I'll try and organize a review sometime on Wednesday, if I can do that. Or even if I can, maybe I can try and fit it in on Tuesday for us. But anyway, we'll do a review of pretty much all of the stuff we've gone over and try and sort of just hone in on what potentially might be on your finals. Okay. Wish I knew more than that. All right. Thank you for your attention today. And I appreciate your time. There's been a
I
little
just
bit.
have one quick question.
Yes.
I'm looking at like the schedule, and it says that it's the practice dosage calc plus the Pharm HESI exam. So it's all gonna be, it's gonna be farm questions and dosage questions, or is it gonna be
Now,
other stuff?
it's gonna, this is the problem, because I set the exam, I don't know what's on the exam.
Okay.
I would go with dosage calc and pharmacology, but I don't know what that's going to look like. I really
Okay.
don't. I hate to do that. That's why I'm saying we should, let me see the HESI practice exam resources. I would definitely do your Saunders books and go through some of the pharmacology pieces and the dosage count like I showed you. Okay, on those NCLEX questions, I would definitely delve in on that. Okay, and look at those. If I can get some more information then I will
Okay.
absolutely for you.
And also, I still can't sign up for the final exam. It's saying the time is from 8 to 12. I don't know if that's why, but I can't do the final exam either on Evolve.
Is all of you having that problem with the final?
Yes, ma'am.
Okay. All right. I've already sent Terry Minwa a question about that earlier today. So it's probably something on their end that they have to fix, and I'll get that taken care of, hopefully,
Okay.
by tomorrow.
That's
All
all I
right.
have.
Start working on the NCLEX stuff. Take this extra time to start using those resources for sure. Those NCLEX Saunders questions. Okay.
Yes, ma'am.
All right. I'll see
You're a
you
strong woman,
Thursday.
Professor.
Pardon?
You're a strong woman.
Ah, thank you.
You're
I
welcome.
appreciate it. Thank you.
Bye.
All right, guys.
All right, have a
Pleasure
good
seeing
day.
you. All right. And you. Bye.